He did his med school at the University of Warsaw, PhD at Copernicus University in Poland, did his residency at UMass, followed by a fellowship at Mass General and Dana-Farber, and he's currently an associate professor at Mayo Clinic, Arizona.
Thank you. Good morning, everybody. Thank you to the organizers for having me. It's a great honor. So we are switching gears a little bit in moving into the world of metastatic disease after these two phenomenal talks in glioma. I will try to walk you through some of the developments in metastatic disease and how we may be changing the way we treat these tumors. So it's obviously a known fact that brain metastases are a big clinical problem. We are seeing a lot of patients at all our clinics. It is a problem of about 200,000 patients per year in the United States only. The frequency of this condition is increasing, and it's increasing because of the fact that we are better in treating cancer in general, and frequently brain mets are a late complication. So we see more and more patients developing brain metastases. We also have very much more successful systemic therapies, and we also have better imaging, as Leland described to us. So we are picking up metastatic disease much earlier than we used to, and we are also able to intervene earlier because of this. Just to refresh your knowledge, and not everybody in this room is very familiar with this, but we generally would divide brain mets from solid tumors into sort of a neurotropic and non-neurotropic. The most commonly seen mets that we see are from breast, lung, and melanoma. Other solid tumors typically do not have the affinity for the CNS as much as the three I mentioned. Prognosis of this condition varies, and it's changing for the better, but historically we would typically use histology as one of the prognostic factors. We would use a number of the lesions, the size of the lesions, and we would also use the extent of the systemic disease because this would determine frequently how aggressive we can be about treating the patient. In the older days, we have been using RPA classes to kind of cluster the patients into those that are going to do better and those that are going to do worse. And you can see from the slide, the major determinant is typically age of the patient. The younger the patient, the better they do. Performance status is, of course, the systemic disease. Nowadays, we have a newer prognostic grading system, the GPA score. This is based on histology of the tumor and also some of the factors that are present in the RPA classes, such as age of the patient, KPS. And as you can see, the more points the patient